Swayam Prabha. Digital India. Educated India.
Hello all, welcome back to our sessions on precision oncology. Here today we will be discussing the most important models, the mouse models in precision oncology. In the last class, we have discussed on the patient-derived explants, and we have discussed in detail the establishment of organoids, and we have discussed on the single organ on chips, and we have discussed on the multi-organ on chips, and we have discussed various examples pertaining to all these particular preclinical models. Even though you have so much of preclinical models before the animal itself, like you have the different cell lines, you have the different spheroids models, 2D models, and then you have the different uh, explants directly from the tumors, then the organoids. Still, you need to have an animal model to completely validate the drug for its anti-cancer properties. So, in today's class we will be discussing on mouse cancer models. So, one of the major hurdles for the development of treatment regimens is the challenge of translating the scientific knowledge from bedside to bedside, which is mainly due to the fact that many cancer models, as I mentioned before, they poorly replicate the patient's tumor. And as a consequence, even though many cancer cell lines they perform well, cancer models they perform well they fail in the cancer traits, even though. So, for example, you have several CAR Ts or several other immunochemotherapeutics which are coming up, but they do not really come as a successful drug in the clinical trials. Although animal cancer models have provided important insights into the basics of cancer, their generation is very time consuming. They require definitely a skill set, and there are a bit example. So, for example, the histopathology, but they have the histological complexity and the genetic heterogeneity of human cancers are typically may not be definitely be reflected in the genetically engineered mouse models of cancer, but they could be to some extent a good representation of the original tumors. So this is like we have studied the stages of different stages of drug discovery, from the target selection till the clinical candidate identification, where the different where animals models are very much important in the different preclinical objectives, and at each stages we really understand how can the preclinical model, right from target selection till the clinical candidate selection, a mouse animal model or a preclinical model is very much is required. So, it will enable, for example, here to enable identify potential combination partners for a target evaluation. Can I evaluate an existing, for example, a TKI inhibitor with any other novel compound or a natural compound? Or and here during the drug mechanistic studies, if I am using for a novel combination, what are the pharmacokinetic and the pharmacodynamic relationships established in this simple models, and how can they really be extrapolated to the humans? And at this particular stage, where to establish the efficacy in multiple models and in the patient derived for the patient endpoints, so different to establish a therapeutic ratio or index is very important. And then for the broadening, here we need expansion across multiple indicators and complex models, and then selection of biomarkers. It's very important to identify what are exactly the biomarkers or the clinical during the or any particular protein, such as or any other RNA or DNA which are expressed. So for this it will be enabled for the patient. If you recollect, if we have been grouping the molecular status of the tumors. So, having a mouse model can really enable us to stratify the monitoring, to stratify the disease and monitor the disease progression. This is a slide which represents the application rates by stage of single testing for all class of compounds here and the oncology compounds. If you really notice that here there are this is for the large 10 pharmaceutical companies in the US and the Europe from the between the periods 1990 to 2000. So if we can clearly notice that only the success rate of coming from the preclinical testing to having approval, it's very, very low. There's a lot of iteration, that is the number of compounds entering the each phase is reducing. So these data suggest that identifying the rate limiting tumor maintenance targets and the pharmacogenic correlates of response during preclinical development for human clinical testings are definitely a priority. So it is very important to have as many of the valid drugs entering for approval. So as a result, there is a need to develop well defined mouse models or animal models for oncology compound. Here we will be discussing why are we selecting mice. Humans are about 3000 times larger than mice and are formed from a proportionally definitely a much larger number of cells, and average which is much more than the 30 to 50 times of the lice. So given the continued lifelong turnover of cells in the bodies of both mammals, this means that the humans undergo 105 times more times of cell division and several times more of mitosis. As the risk of genetic damage includes the creation of a mutant alleles that lead to cancer, it will definitely increase with respect to the increase in cell division. So that means humans should have a very definitely a higher chance of having more cancer than compared to the mice models, or the higher chance of the rates of cancer incidence is very high, as the risk of the genetic damage including the creation of mutant alleles is also increased. But there are several epidemiological studies that reveal that the lifetime risk of development cancer here, if we can see, is comparable in both the species. If we can see, even though the mice survival is only 2 years and humans have an 80, but the risk is almost the same in both. About 30% of laboratory mice models have cancer by the end of their 2 to 3 lifespan, and about 30% of people have cancer by the end of their 70 to 80-year lifespans. Moreover, even though the rate of the cancer increases with age in both species, 30% of the individuals may not have cancer at the age of 3 years, not even 30%, it may be even a much more, several of the individuals. So a marked decrease in age specific cancer rates has accompanied a substantial increase in lifespan that has occurred during the past 80 million. So this is over the process of evolution. So, that is why we were able to adapt mice model by virtue of having the similar percentage of cancer risk. But and also mice genome is highly homologous to the human genome, and it can stimulate a series of biological characteristics. The development and metastasis of the human cancer cells in vivo has the advantage of conveniently feeding, and it also provides a good tool for cancer research during drug discovery and verification, as we will see in the coming models. Under certain conditions, the occurrence and development of animal disease are similar to that of human beings, and animals have similar anatomy and physiology, that is and hereditary of human beings, that is when some of this mammalian models. Therefore, the animal models are very well preferred to study human diseases. When coming to cancer models, the use of animal models can help us understand to define the genetic basis of cancer and the role of specific genes and gene mutations in the occurrence and development and progression of cancer. So, and it can also facilitate the development of new anti-cancer or anti-cancer or anti-neoplastic drugs. So, with the continuous development of precision medicine and personalized medicine, there has always been a lookout for standardized and personalized tumor models that are more similar to human tumors. So, based on the cancer animal models, so we have the small animal models and the large animal models. such as the pigs, the monkeys, and here we have the mice, the rats, and the zebra models. And here the chemical, we will continue to discuss what are the characteristic of each one of these models. We have the chemically induced model, the tumor transplantation, and the genetically engineered molecule. So among the tumor transplantation, we have the xenotransplantation models and the allotransplantation models, such as your, and here also we have the cell line derived models and the patient tumor derived models. This timeline shows the first available reports of the animal model testing, which date back to the Aristotle, the first, where he brought in the first evidence of animal use research, which over time and over time we have recognized the evidence of animal usage in cancer drug discovery, or for envisaging the role of the cancer progression and the tumor progression. So the first cancer development, the first assessment of how cancer develops, the chemical carcinogen was identified, the first carcinogen was identified, and then the production of the DBA in inbred mouse, which are cancer models, and the cell line production. The first cell line was established. If we get elected, we came across this milestone in our earlier class, and the first xenograft model and the first PDX. So this xenograft is a cell line derived, and there is the genetically engineered mouse models are also were developed. So broadly, all the mouse models are cell line derived transplantation models, and there are the patient derived xenograft, genetically engineered mouse model, and the oncogene. So now, how are the production of the mouse models? So we have the syngeneic tumor models, which are produced by transplanting the mouse tumor cell lines into an immunocompetent mouse in a short period of time. So and here, this is the in genetically engineered model. The tumor forms here from the patient. It is also similar to the surgically resected tumor is or it's taken, or it is also like tumor forms as a result of the specific genomic modification. And then in the mice, this is the syngeneic tumor models. Here we see how these different molecule models are formed. Here it's a syngeneic models, where the models are produced by transplanting the mouse cancer cell lines into the immunocompetent animals in a short period of time. And then here in the genetically engineered tumor models, the tumor forms a de novo as a result of specific genetic modifications, such as the knockouts of your P53 or the activation of the oncogenes. And then we have the carcinogen induced models, where the UV light or any other chemical induced carcinogen, by such where the spontaneous tumors are formed. And then for the production of this patient derived xenografts, which we will be discussing in detail. So in this syngeneic mouse model, transplantation of the in vitro tumor cells into the immunocompromised, which will commonly utilize approach to investigate the anti-tumor therapy, and including even your immunotherapeutics and spontaneous carcinogenic or transgenic tumor cell lines can be transplanted into mouse strains, such as your C57BC or BLAPC and FWB mice. So the creation of this models takes a short period of time, since transplanted subcutaneously only. So keep in mind the place of transplant also, or engraftment. So the first kinetics of tumor growth in a syngenetic models often provide it may not be very much adequate enough for the time to evaluate the effectiveness of a immunotherapy. So also in syngenetic mice, it is possible to evaluate the effectiveness of immunotherapeutic drug at earlier stages of the tumor development. In the syngeneic models, some of them, the tumor cells are injected subcutaneously, as it is easier to track the tumor development by measuring the size of the tumor. In order to make a TMB maybe closer to that of the human people, the tumor cells can be orthotopically transplanted into the corresponding organs such as the mammary pads in the mouse, or the intravenous administration of leukemia cell lines, or pancreatic injection of the pancreatic PDAC cell lines, or the intracranial injection of the glioma cell lines. So they are all organ specific. The administration routes more accurately reflect the TMV, but require more complicated skill set, manipulation, and definitely some equipment for both the transplantation and monitoring of the further tumor development. So the TME may prove to be an unnaturally homogeneous. The syngeneic models of tumor also lacks genetic heterogeneity, which makes each tumor unique. So the absence of mutational, because it's by the virtue of the cell line derived in syngeneic tumors, is partly due to the absence of your cancer stem cells which are not there, and other populations of the progenitor cells that are present in the TMB and provide a constant source of new mutations for tumor evolution. If you recollect, in our last class, the first slide where we have shown the different cells in the TMB, in addition to cells intended for transplantation, often go through adaptations in a harsh or in vitro or in vivo sessions, which leads to the decrease in the heterogeneity of tumor cells. The syngeneic models are first very well employed to study the efficacy of the CAR T cell modules, or the cell derived CAR T cells are used. Mouse models allow for the toxicity of CAR T cells to be determined, which depends both on the presence of the co-stimulatory dependence and the chimeric receptors of the CAR T cells. A syngeneic model of lymphoma of a biopsy mice originally showed that the first generation CAR T cells without the co-stimulatory domains killed the lymphoma cells but did not cause very side effects, which is a breakthrough. But the second generation CAR T cells with the CD8 co-stimulatory domain induced a B cell aplasia and chronic toxicity accompanied with the increase in number of the suppressor cells. So it should be noted how the difference between the two generations of CAR T cells is playing a role here. Syngeneic models are also very well employed to investigate the anti-tumor activity of your immune checkpoint inhibitors, including the anti-toxic T-cell lympho-associated anti-CTLA4, which we have discussed in the immune checkpoint immunotherapy slides, and the anti-programmed PD-1 and the anti-PDL1 antibodies. They have been very, very helpful for using the syngeneic models of the using the syngeneic model of the immunocompetent B6 mice transplanted with the hematopoietic cell line or its analog with PDL1 deficiency. You even have the mice. It has been shown that the PDL1 pathway blockade contributed to the rejection of tumor cells in mice transplanted with the wild type EG7 cells or the PDL1 deficient EG7 cells. So this is the importance of the syngeneic models, mice models in your CAR T cells. This slide will give the comparative characteristics of mouse tumor models which we have discussed. So here we will be discussing about your humanized mice, the stem cells and the PBMC humanized strands in the last part of the session today. So here we can clearly see that how the heterogeneity of the tumor is very low in the syngeneic mice, but whereas it has been a little high in all other molecules, and it is rather easy, for example, to set up a rapid tumor development. But here it depends on the patient, because it depends on how aggressive the patient is, tumor is, and how it's a different model. So it is definitely a trial and tested model for each patient here. So sometimes the breast, it may not be really as homogeneous as it is here, and here the tumor does not have a natural microenvironment, but most of the TME is transplanted from the patient here. The tumor forms from a natural microenvironment here in both this carcinogenic induced mouse models and the GEMS. And the complexity of the immune system is also discussed here. This is based on the graft versus host rejection because of using the immunocompromised mice. It's less, and then The price is a little bit low, but whereas it's very high for all the other models. As mentioned before, cancer cell line transplantations are based on the orthotopic inoculation of the cultured human or mouse cancer cells in immunodeficient or the syngeneic mice respectively. The patients here derived patient derived tumor xerograft models or GEM derived models are based on the direct orthotopic implantation of human or mouse tumor fragments in immunodeficient or syngeneic mice respectively. Here in the oncogenic mice, the tumorigenesis is induced by the transgenic expression of one of the particular oncogene from a tissue specific promoter. So in tumor suppressor gene knockouts, here as we can clearly see, the de novo tumorigenesis is induced by the germline inactivation of a tumor suppressor gene. Here this is the conditional E and F represents the conditional genetically modified mouse models, which is induced by tissue specific Cray-Lox-P inactivation conditional TSG alleles. Here we can see the evolution of mouse cancer models, where the cancer cell transplantation models are based on either the orthotopic inoculation of the cultured human or mouse cancer cells in the immunodeficient or the syngeneic mouse models. And here the patient derived tumor xenograft models or the GEMM, that is your in the session GEMM will be referred to as genetically engineered modified mice. Derived tumor are based on the direct orthotopic implantation of human or mouse tumor fragments in immunodeficient or syngeneic mice respectively. In this particular oncomice, de novo tumorigenesis is induced by the transgenic expression of an oncogene from a tissue specific promoter or and in a tumor suppressor gene case, a knockout mice where a de novo tumor is induced here because of the absence of your TSG gene. So, having the advantages and different advantages, we have been able to discuss about the allowed here. We can be clearly seen that whether the genetic validation of the drugs is clearly possible in all these particular models, and the preclinical testing can be used using in any of all these models. And however, other than the allograft cell in immunotherapy, nothing much of this particular models have been have been well utilized. Here again, grouping of my models happens to the indirect xenograft models or the direct xenograft models. In the indirect xenograft models, the cell lines which are derived from the patient tumor, either they could be the original cell lines or the established cell line in the lab from the particular patient, and then they are grouped into the orthotopic tumors or into an heterotopic tumors. The direct xenograft models are directly from the patient tumor, and these represent the original patient tumor heterogeneity and the TMB along with the other genotype and the phenotype characteristics of the tumor. And the orthotopic direct xenografts are derived directly from the patient and without a cell line intermediary, and they are subsequently put it in all the both either in an heterotopic or orthotopic site in the immunodeficient mice. So, as we mentioned, this is the model for a subcutaneous implantation or a heterotopic implantation, and then we have called the orthotopic implantation. Here in the simple way, the cancer cell lines are inoculated subcutaneously into the flank of the mosquito. They can be either a syngeneic or a xenograft, I mean either a mouse or the human cell lines, and the ease of the monitoring and engrafting can be easy, and the size of the tumor can be measured with the calipers externally, and it is a very time and cost effective, and several labs are using to this till now to date to test the efficacy of the novel anti-cancer compounds. As mentioned before, they do not have any resemblance to the original tumor, whereas with an orthotopic implantation, meaning they must be, as I mentioned, the different sites before, the immortalized cancer cell lines derived from the cancer patient, and they are implanted in immunocompetent mice, and then or in the syngeneic mice. So it is then they could be implanted in the same site as the origin of the tumor tissue. So though it is good and reproducibility for target validation and for candidate selection, some of these models are representative of clinical tumor microenvironment. This can be leading have to be a there is so much of in vitro passaging, and that too in the different strains in the different mice models, which is different from the human. It can be lead to many of the original characteristics of the tumors also may be lost. Here, this slide represents the timeline of the PDX models which have come into existence from the first reported 1969. So, although many mainly refer to the genetically engineered models when bringing up when bringing up with the concept, because of the confusion with the PDX and the GEMS. PDX models have gained a lot of wide acceptance and importance in right from the beginning. One scientist in 2016 has generated almost 100,000 PDX models and trusted drug responses from them following a clinical trail design, and this is called the patient derived clinical trail, PCD. So this has been widely accepted from where, and the wild application of your NGS sequencing to further characterize the validate the genome consistency between patients and the PDX. So you have the original parental tumor from the patient, and as well as the PDX established in the mice model, and as well as the drug treated PDX, and that will be used as to and a comparison of the genome or the histopathology of this particular tumor. Therefore, in this particular era of all the targeted therapies and the precision oncology and immunotherapy, clinical PDX models have really gained momentum in the preclinical drug test. So, they are serving as the avatars of tumors and the corresponding donors, and they can guide clinical decisions by predicting if the drug molecule is going to really help in the prognosis or the outcome of the therapy for the patient. So there is a concept of mouse hospital which came up, and it refers to the in vivo drug testing in models. So, as we have discussed, they maintain the molecular genetic and histology heterogeneity typical of tumor origins through several passages. They represent an information rich preclinical resource for analysis of the drug activities, about the including the novel drug combinations, and as well as predictive the biomarker discovery. Therefore, to keep in mind importance of diagnostic biomarkers or the prognostic or therapeutic biomarkers can be discovered during using this patient derived models. This is a very quick advantage over other models, as we can clearly see is they preserve the genetic landscape. Suppose even if the mutation, for example, the stomach cancer, the BRAF and the KRAS, the morphology, it still continued to maintain the genetic landscape. And coming here, it also maintains the heterogeneity and specific trails. And as mentioned, cancer immune interaction, all the cells, if you recollect, the first slide in our last session, it's all well recollect. And then they reproduce clinical observation. For example, a drug has been sensitive to one group of mice. Yes, it could be continued to be sensitive to the same, provided the same conditions are used. This represents the protocol for establishment and testing of patient-derived tumor models, xenografts. So here, after taking the patient consent during the surgical resection, that part of the tumor which is not required for diagnosis, such as for the histopathology or making a FFP block, they are obtained after the consent patient's information. Then they have taken the non-necrotic regions are taken off, and the tumor bits are sectioned into approximately 3 mm square pieces, and after processing and implantation subcutaneously into the anesthesia 5-week to 6-week old female athymic nude mice. We will be discussing the mice models slowly. During the engraftment phase, tumors are allowed to establish and grow and then they are harvested upon reaching a size of around 1.5, or based on the different cancer type and different established conditions, 1.5 centimeters. So, and then after they are excised, they are passaged through different different passages, that is the F3 to F5, and typically biological assays are performed on tumors in generally in early generations. So these includes the drug assay, efficacy assays, such as you can even treat the mice with the particular drug as the same drug as given to the patient in the clinic, and and if the developed biomarkers achieved accurate prediction in the validation set of the PDX models, they might be translated into early phase clinical trials as tools for patient selection strategies. So here we can see how the biomarker, suppose you have the say copy number variation or a gene expression for a resistant for a drug resistant variety PDX model, this particular could be main, and for a sensitive it could be a gain in copy number. So and then we have the integrative genomic cluster and the different particular, so you can clearly predict where biomarker positive and they don't respond to the drug, and a biomarker positive the drug is given, and the biomarker negative the drug is may not be given, and thereby eliminating the patient from toxic effects of the particular cancer drug. Here we will be discussing about some of the endpoint assays such as your qRT-PCR Western blotting and the RNA sequencing to and the whole exome sequencing and the drug sensitivity testing on these tumors and the immunohistochemistry analysis. And then we will also see, here we will be seeing that the PDX engraftment rate, how does it alter? So what is PDX engraftment? It is the ability of the tumor to establish in the mice. So it could be they, as I mentioned before, the primary tumors are cut into small pieces and transplanted with maintained tissue structures. So they can be either be administered subcutaneously in an orthotopic or a heterotopic transplantation. So different tumor types take different duration to establish PDS, ranging from ranging from several few days to 6 months. Generally, when the tumor reaches a particular size, it is usually passaged into the next generation. So the time of PDX establishment gradually stabilizes at with a time of say 40 to 50 days with passages. So, and to avoid tumor engraftment rejection in mouse model, conventional PDX models are typically created using the immunocompromised mice, such as your athymic nude mice, your skid mice, non-obese squid mice, or the NSG mice, that is your IL-2 gamma receptor mice, the BLAB-C RG null, and the IL-2 gamma, that is your BRG mice. And we can clearly differentiate how the engraftment efficiencies are higher in more immunocompromised mice. So, for example, the BRG mice is more, or the BRG and the BRG mice is more greater than your NSG mice, and then compared to your NOD or the skid nude mice. So, to establish the PDX models, primary and metastatic tumors are cut into the species as mentioned, and then how is the any pre-treatment? So we have two types of PDX clinical trial, which is for the de novo compounds, or where a PDX biorepository, the tumor biopsy is established into different mice models, and after passages the drug sensitivity is taken care. So, and here, whereas in the core clinical trial of the mouse models, along with the patient, the same therapeutic or a combination of a novel therapeutic is given to the patient alongside with the mouse model. So, a typical data analysis and real-time integration happens where the mouse response to the drug is also studied, and that any of the particular biomarker expressions or the different genes or any of the novel variants expressed is also studied. So, here the drugs are optimized and improved outcomes of the clinical efforts is already studied in this particular clinical trial method. In the new era of cancer treatment, PDXs are playing a very important role by restricting the beneficiaries, like for example, eliminating people who do not respond to certain kind of drugs as seen before, and they carry the tumor heterogeneity, which will help for the for retaining the predicting the drug response, which will help for the targeted therapy, and immunotherapy and novel therapeutics are all completely used in this used to test in the PDX models. And this is all the slides which we have gone in detail in the previous slides. A very important development in the development of mouse tumor models is the creation of mice in the autochthonous tumors, which develop in the specific tissue due to the inclusion of specific changes in the genome. GEMs are usually produced using transgenic technologies to provide synthetic and tissue specific expression of oncogenes such as the KRAS and the MYC in the breast, and or a deletion of a cancer suppressor genes such as your P10 or your TP53 in the prostate cancers. These transgenic models can be further divided into germline GEMs and the non-germline GEMs. Germline GEMs have mutations that lead to the spontaneous development of malignant neoplasm. So, it has been shown that in the mice with the TP53 gene mutation, a wide range of solid and hematological malignancies develop. Germline GEMs have allowed the detailed study of the mechanisms of tumor formation and development, but it is very labor intensive and does not allow the control of the movement of place of the tumor onset. Non-germline GEMs are also very important, and they on the other hand provide the spatiotemporal control of the onset of the tumor or at the onset of the transformation. So, induction of somatic mutations at a selected time and in a specific tissue can be using various systems. For example, the tamoxifen inducible Krelox-P system, in which after in endogenous activation of the CRE recombinase by the tamoxifen, any gene flanked by the LOX-P recombination site is deleted. So, even several RNA interference mechanisms using your shRNAs are used to create many non-germline models. So, here we can clearly see the different uses of the GEMs in both in the cancer basic research as well as translational oncology, and this is very well used especially to identify your drug target validation and the tumor interventions. To find the most effective treatment for cancer types, we heavily rely on this particular preclinical research in animal models. Even though several success is reported in validation of these animal models, many anti-cancer therapies in conventional models are based on the xenotransplantation of established human cancer cell line and may not be necessarily or allotransplantation of mouse tumor cell lines. Thus, the overall poor clinical predictability of the conventional in vivo tumor models required for the need of this preclinical GEMs and which have a better predictive power. Until fairly recently, progress in this field has really been hampered by the poor availability of preclinical models that closely mimic the human cancer models. So, GEMs have become here of great importance to improve our understanding and for the complex mechanism underlying the cancer biology, and they are very much important in the translational oncology for having a better therapeutics. So, thus the high attrition rate of clinical compounds, which we have shown in the earlier slides as potential cancer drugs, indicates a better methods to predict the efficacy, and here the GEMs can play a role here. The poor correlation between the therapeutic activities of compounds tested in xenograft mouse models and the efficacy in humans has not necessarily mean that they may not be very well good models, but that is why there has been a need for generating GEMs. This diagram represents the comparison between xenograft versus GEM. We have discussed the xenografts in detail before slides, whereas for the GEM, here the somatic inactivation of an activation of an oncogene and or inactivation of a tumor suppressor gene will lead to the generation of tumor bearing gems, and when during treatment with serial assessment, which may take to 2 to 10 months, the response or progression of this particular tumor or the mice can be done here. This particular mice are TSGs are inactivated somatically and generally through temporally control and tissue expression, specific expression of this particular CRV recombinants. Animals then develop in the tissue tumors in the tissue of interest, especially in this particular case, it is the lung. So, tumor bearing genetically engineering mice are then, when treated with the compound, are serially assessed for the response. So, this is the MRI scans as generated from the lung cancer. So, GEMS show the initial development of the tumors followed by rapid response here, which is and that means they are responding to the orally administered small molecule kinase inhibitor. This particular slide gives the factors contributing to the success of PDS engraftment among the different cancer types. For example, in hepatocellular carcinoma, because of the lack of encapsulation or the poor tumor differentiation and overexpression of the cancer successful stem markers, the PDX are successfully able to implant. Between the there and this, if you can correlate the success of the PDS engraftment and the patient prognosis, this could be an indicative. It could be an independent predictor for overall survival, and because it's a post resection tumor recurrence. So, it's after the surgery the tumors are taken. So, basically the clinical surgeon has removed the tumor causing tissue. And it is like the sooner as I mentioned that before, that sooner the tumor establishes in the animal, the more aggressive it could be. So, it could be likely event that they may not likely to be efficient on they cannot be likely to respond to the anti-cancer therapy which the patient is taking. And this gives the different for other tumors as well. And for example, here the PDAC also we have the 59% success rate for the reasons of which are not listed. For even for the lung squamous cell carcinoma was correlated with the preoperative chemotherapy initiation. This slide will be talking about the 5 common PDX models and their properties here, which have been developed for various cancer over the years and have been used for tumor evaluation and the drug screening. The model is reviewed worldwide, and here the tumor uptake rate for the squamous cell lung cancer is around 24%, and the FDA approved markers are like for the EGFR, and then you have the MMP7. And these markers are used for the diagnosis. So, if you recollect our cancer detection methods, yes, an EGFR diagnosis or the EGFR mutation status is a definite validation before ascertaining the patient therapeutics. Then for coming with the gastric cancer as well, the MAST or the stem cell growth factor receptor and the KIT. So, they have been approved biomarkers which are also used in diagnostics. So, for example, even in the breast also there are very important like your ER and the progesterone receptor and the HER2. So, they are useful for the monitoring disease, treatment response and therapeutic selection. So, these are also very important biomarkers which are used both in the age-old histopathology as well as in the novel NGS technologies and as well as in the PDX. This slide lists the different immunodeficient mice which are well employed for the cancer biology. So, this development of immunodeficient mice occurred during the it has been studied with the 4 main stages. The first stage, which included the nude mice that are the simply deficient in your T lymphocyte owing to the abnormal thymus deficient. So, however, the application of nude mice in many diseases has been known to be limited because of the low relative degree of the uh, immunodeficiency. The second stage included mice with the SCID, which carries the mutation at the PRKDC gene. So, SCID mice are deficient in both the T and the B lymphocyte, but retain the natural killer cells and show leakage. The SCID mutation has then been introduced into a non-obese mice with the natural killer deficiency, natural killer cell defects, to obtain the NOD or the NOD SCID mice, forming the third stage of your immunodeficient mice. However, these mice exhibit a high frequency of spontaneous thymic lymphoma and short life cycles as well as partial NK cell activity. Therefore, their application as humanized animal model has been limited has limited activity. To improve this stage, the fourth stage, which comprises of the immunodeficient mice called the NOD SCID RG null mice, was developed by the knockout of the IL-2 receptor gamma chain IL-2 RG. So, these knockout mice have a higher rate of human cell implantation without leakage or spontaneous thymomas, and they are being used as the golden standard for immunodeficiency mouse model. So, first we have really discussed the nude mice lack the FOXN1 gene. Here you can clearly see how the evolution of the mice models have happened from a complete no multi cells till the residual. As mentioned, the nude mice are the earliest immunodeficient models, and they were first reported by Flanagan in 1967, and there is a FOXN1 gene which prevents the thymus development, therefore leading to the mature lymphocyte T cell lymphocyte deficiency, and this mutation happens in chromosome 11, and the main immunoglobulin in this mice is IgM. So, there are several commonly used strains as listed here. Some researchers found the CB17 inbred mice, they carried a recessive mutation of a single gene on chromosome 16, which led to the abnormal recombination enzyme activity of the sequence encoding the mouse lymphocyte antigen receptor gene VDJ, due to which the immunoglobulin T and B receptors could not be synthesized effectively. So, this RAG1 and the RAG2 induce VDJ rearrangements of TCR and immunoglobulin genes by producing the DNA double-stranded breaks. So, this mutation obstructs the repair and the construction or recombination of the TNB lymphocyte cell receptors, and it affects the differentiation and maturation of these cells, resulting in lack of the mature TNB cells and low immunoglobulin levels in the peripheral blood or in the lymphoid organs of the SCID mice. So, they are highly sensitive to radiation. Engel mice were generated by the knockout as mentioned before. So, these mutations lack mature TNB lymphocytes. There is a non-obese diabetics NOD mice via inbreeding and selective breeding. So, with the changes and characteristics similar to those in the human diabetes. So, introducing the SCID mice into the genetic background of the NOD mice was hypothesized to result in their NOD SCID mice. So, with simultaneously defective, adaptive, and both innate immunity. So, successfully researchers introduced the SCID mutation into the NOD mice in 1995, which is the genetic background of the NOD mice. So, they had a functional loss of the T and B lymphocytes as mentioned before, and other immune cells, as well as there is a defective and natural killer cell function, which resulted in higher degree of immunodeficiency than in the previously noted mouse models. So, human B cell restructuring in nude mice and the SCID mice was poor. So this had specific characteristics of low NK cells as mentioned, complement C5 deficiency, and IL-1 secretion is defective, and these characteristics enable the generation and survival of human cells and grafts. So it is at a very high level. This non-obese mice and skid mice were able to accept the engraftment. So, if you recollect, go back to our session on mechanism of carcinogens, we have highlighted that many of the chemicals can induce carcinogenesis. So, tumor formation in mice can also be induced by this carcinogens. Some of your well studied carcinogens include your MCA, that is methylchloranthrene, or your UV induced carcinogens, or the tobacco induced carcinogens for lung cancer, or dextran sodium sulfate introduced colon carcinoma. So, for each organ differently there have been chemicals that induce carcinogens in mice. So, many carcinogens such as your N-methyl and nitrousar are used to create mouse, rat and other mammalian models to investigate the anti-tumor therapy for drugs. So, even though genetic instability is created by the mutagen, this allows, and as such it allows for the formation of a de novo tumor formation, and in this corresponding microenvironment, these tumors require slightly a longer time to establish. However, they have a great genome complexity which accurately reflects the real neogenesis of tumors in a human. Moreover, due to the greater mutational burden in the mouse model, different levels of immunogenic neoantigens are potentially generated, which will definitely have an effect on the immunogenicity of the tumor. However, this carcinoma-induced models are not very well efficient for CAR T therapy because of the many number of neoantigens which are induced. So, carcinogen-induced mouse models have been instrument in defining or supporting the cancer immunoediting theory as demonstrated by the many studies. So, here this is an MCA induced carcinoma, which we have said it's an cancer induced mouse model, MCA induced carcinoma in mice. As mentioned before, carcinoma induced mouse cancer models have been very instrumental in supporting the immunoediting theory as demonstrated by this MCA induced sarcoma in mice, where they have a genetic deficiency in their monoclonal antibody targeting, as we can see here. So, they have a genetic deficiency in or monoclonal antibody targeting as targeting of the immune components with that of the wild type control animals. So, MCA induced sarcoma from immunocompetent mice can be transplanted into the second immunocompetent mice by hence exhibiting a progressor tumor phenotype. By contrast, sarcoma induced in the immunodeficient mice, for example, this particular uh, immunodeficient mice fails to grow or regresses shortly after transplantation into the immunocompetent recipients. As such, tumors have not undergone any immunoselection owing to the absence of the B cells, T cells and their natural killer cells. These findings support the immunoediting theory. There is a need to construct humanized mice, where essentially a humanized mice is one that where the human immune cells are engrafted into immunodeficient mice models, which include inoculation with the PBMCs as shown here, or inoculation with CD34 hemopoietic stem cells as indicated here, or simultaneously engraftment with human fetal liver and thymic tissues. So, engraftment with the human PBMCs via the intraperitoneal injection is very common, and it was first performed in 1988. Over the time, immunodeficiency humanized models were improved, and an advanced NSG mice which show a high chimerism rate, the development of human and erythropoiesis and thrombopoiesis, and the formation of the hematolymphoid compartments have become the basis for development of today's humanized mice models, and here the NSC mice play a very high good role. So, even though many of the cancer antineoplastic drugs have a good therapeutic effect in the preclinical animal models, they cannot mimic the same in the human models. Therefore, it is necessary to establish an animal model that can not only replicate the tumor microenvironment but also have an humanized immune system. Please note here, the humanized mice is nothing but the humanized immune system at the same time. So, the humanized model of the human immune system is a mouse model that reconstructs the human immune system by implanting the human hemopoietic cells, lymphocytes or tissues into the immunodeficiency mice, as we have shown here. The different kind of the PBMCs, KMCs and the different are all implanted into the mice. So, at present, a variety of human tumor cell lines have been successfully been established in humanized mice such as the lymphomas, gliomas, breast cancer and the prostate cancer. So, according to the method of human immune system reconstruction, the humanized mouse models of the immune system are divided into the three categories. We have the HUBLT, that is the human bone marrow, liver and the thymus model, the HUHPVs, the hemopoietic cells, and then you have the HSCs, that is the humanized hemopoietic stem cells, and the HUPBL, which is the humanized peripheral blood. So, these are the different mice models, and the HUHSC models needs to destroy its main function is to destroy the hemopoietic function of the bone marrow in mice. Here we are showing the genetic humanization of individual targets or the entire portions of the mice immune system. So, to overcome the different considerable differences between some of the biological machineries in these mice and humans, knock-in mice can be created by replacing a mouse immune gene with the human equivalent. Moreover, mouse immune editing portions can be deleted, and human edit equivalents, which are encoded as transgenes, can be inserted into the mouse genome, which results in the recapitulation of the unique profile of the human immune portion. Please keep in mind, we are just recapitulating the unique profile of the human immune system. Humanization of individual immune effectors. For example, the specificity and functionality of the specific several human effectors is very much different here, as we can clearly see. So, and this is functionality, the specificity and function of several human immune effectors is different from that of the rodents. For example, NK cells as well as some subtypes of your delta gamma T cells corresponding to lipid antigens, they are all different. So, immunodeficiency mice and NSG mice may be engrafted with human cell populations to study their effects on the human cancer models. So, this is very, very important here. So, humanization for xenografts. For example, only mice bearing a gene major immunodeficiency can tolerate a transplantation with human cells. So, these mouse strains can be further optimized to support human innate immune system effectors through the replacement of the endogenous mouse cytokines with the human equivalents such as your interleukin 3, your GMCS, that is the granuloid macrophage colony stimulating factor, and your thrombopoietin. The immunodeficient mice may be reconstructed or reconstituted with peripheral blood PBMCs from the patients or the tumors, and that too from the same patient exactly, to predict clinical response to the novel therapeutic interventions. So, these are the three different processes of genetic humanization of individual targets. This is the strategy for developing immune checkpoint blockers. In the standard transplantable approach, histocompatibility cancer cell lines are injected into the immunocompetent inbred mice. After few days after the tumors are established, and the tumor growth, tumor infiltrated lymphocyte populations are harvested and studied. In an innovative approach for discovering for new immunotherapy targets, T cells are usually infected with transfected shRNA libraries. So, that may into the tumor bearing mice to identify particular shRNA libraries that could be or to that could which when to identify particular shRNAs that enable T cell accumulation in tumors. So, this can be done by deep sequencing of the shRNA cassette within purified T cells collected directly from the tumor. So, this particular identification of immune cell death, where here it is called the ICD, which comes here, identification of the ICD, identification of the immune cell death inducers, it happens here. So, a cancer therapy can be defined as an inducer of uh, immunogenic cell death if it fulfills two criteria. First, the vaccination of the tumor cells killed in vitro with the ICD inducing intervention, which elicits a protective tumor antigen specific immunoresponse in the immunocompetent mice, and only mice bearing a major immune deficiency can tolerate this transplantation with the human cells, such as your NSG mice. So, immunodeficient mice can be a cancer therapy can be defined as an indicator of immunogenic cell death if it fulfills two criteria, such as the vaccination of the human cells killed in vitro with the ICD inducing intervention, and which elicits a protective tumor antigen specific immune response in the immunocompetent mice in the absence of any adjuvant. It is very important, there should be no adjuvant. Second, chemotherapy with this ICD inducer but exert anti-cancer effects that are dependent to the on the immune system. For example, effects that are suboptimal in your which are suboptimal in the immunodeficient mice treated in the same manner, as we can see in the D part here. So, the combination of the immunogenic cell death inducers and the combination of your ICBs, that is your immune checkpoint blockers, can induce a very protective or a greater therapeutic response, as shown by the shRNA libraries which are transfected into the T cells. So, coming to the end of this lecture, we have seen the bedside to bedside translation of the ex vivo models and to the and of the in vivo models, the PDX. So, where we have thoroughly understood the various concepts of the 2D cell layers, the organoids and the organ culture, and then and definitely in the clinic after the informed consent, it is definitely required to maintain them in the PTX, and we have really discussed about the different advantages and disadvantages of the different models. So, in the today's session, we have checked about the complete mouse models for the cancer cancer research. Why is it important to have the mouse models in the cancer research, and the different types of mice models used, and what are the different types of the gems which are produced, and what are the humanoid. So, we just got introduced into the different mice models in the used in the cancer research. Thank you.